So let's get started with some technical issue. This is a session about trial and evidence. I think there is also some change in the schedule. So the first talk is by Will Farron, and he will present the 5-year result of the phase 3 trial.
Thank you, Mario. And thank you, David, and thank you to the organizers of ICC. It's a real honor and pleasure to be here. You know, when I was thinking about this talk, I was hoping that this is not going to be the case where I'm being thrown to the wolves, but we'll see how it goes. So as a reminder, the FAME-3 trial is an investigator-initiated, multi-center, randomized controlled study of all comers with 3-vessel coronary disease not involving the left main. That each heart team at each site felt was amenable to PCI or CABG at 48 centers in Europe, North America, Australia, and Asia. And patients were randomized in a 1-to-1 fashion to either FFR-guided PCI or to CABG. And the primary endpoint was a 1-year composite of death, stroke, MI, or repeat revascularization. We did pre-specify a key secondary endpoint looking at just death, stroke, or MI at 3 years and at 5 years. And I know there's been some question about us changing the endpoint, and I wanted to clarify that the endpoint was not changed. This is the design paper we published back in 2015 when we were first starting the trial. And in that, we clearly state our primary endpoint, as I mentioned, and the key secondary endpoint being the rate of death, MI, or stroke. We recognize that those hard endpoints were important ones, particularly at longer-term follow-up. The reason we included repeat revascularization and a 1-year time point was because we wanted to recapitulate what was done in syntax and then be able to compare how a newer generation stent and the application of FFR changed the outcomes. So when looking at the procedural requirements in the study, I'll focus on CABG. FFR-guided CABG was not mandated, but if it had been performed, the information could be used. Patients were pretreated with aspirin and high-dose statin was recommended. On or off-pump CABG was acceptable. A Lima graft was to be attempted in all cases, and complete arterial revascularization was strongly recommended. And as I think most of you know, at 1 year, PCI failed to meet non-inferiority compared with CABG when looking at the composite of death, stroke, MI, or repeat revascularization. The p-value of 0.35 means that it didn't meet that criterion. When you look at non-inferiority trials, if the p-value is significant, then the treatment is reaches or achieves non-inferiority. Now, in the initial abstract that we submitted to the New England Journal, in the conclusion we said that bypass surgery was superior to PCI. The New England Journal of Medicine and the statisticians stipulated because the trial wasn't powered specifically to look at superiority, you cannot make that statement. And so that's why that was removed. The other thing I mentioned is that we wanted to compare FAME-3 to the previous landmark trial, the syntax. This shows the baseline characteristics of the two patient populations. You see that they're very similar: age, risk factors, complexity of disease, number of lesions, and similar syntax score. And when you look at the outcomes of the syntax trial with respect to PCI and CABG, and then you overlay the outcomes of the FAME-3 trial, you see that actually PCI in FAME-3 performed quite favorably, well better than PCI and syntax, and similar to what was seen in CABG. And that's what we expected, but what happened was that the CABG arm actually did a lot better in FAME-3. And so that's why we failed to meet non-inferiority. The other thing you notice is that the difference between the two has narrowed compared to the syntax trial. Now, as I mentioned, we looked at the 3-year endpoint of death, stroke, or MI. There was no significant difference, although as you can see, there was a strong trend favoring CABG. This was due to about a 2.9% difference in the rate of MI. When you look at death, there was no difference. Stroke was slightly lower with PCI. And so one of the questions that we had was, at 5 years, will this difference in MI continue to grow? And will a difference in survival emerge like it had in other studies like Syntax? So in the 5-year follow-up, we had roughly 95% follow-up in both arms. Again, the baseline characteristics are shown here. They were similar between the PCI and CABG arms. The procedural characteristics are shown here. As would be expected, the time to procedure, the procedure duration, length of hospital stay were all significantly shorter with PCI. The number of lesions was similar, and you can see these were fairly complex patients with an average Syntax score of 26. When we look at the procedural characteristics in the bypass arm, 10% had FFR measured prior to CABG. 3.4 distal anastomoses were placed on average. 25% of patients had multiple arterial grafts. Lima was used in the vast majority, and off-pump surgery occurred in about a quarter as well. This slide's an important one. This shows the medical therapy that was achieved at 5 years. And you can see that there was an extremely high rate of antiplatelet therapy, statin therapy, as well as other medications that control coronary disease. And this was significantly better than what had been achieved in Syntax, and I think also helps to explain some of the differences in the outcomes. So at 5 years, looking at death, stroke, or MI, we see that there was no significant difference. 1.9% absolute difference. The p-value was 0.27, still favoring CABG, but not statistically significant. And importantly, when we look at the landmark analysis, you see that all of the difference occurred during that first year. We did not see a late accrual of benefit, which was surprising to us and not expected. When we look at the individual components of the composite, death was identical between the two groups. Stroke was numerically lower with PCI. Myocardial infarction was higher with PCI, but the absolute difference was the same as it had been at 3 years, which was interesting, about 2.9%. Repeat revascularization was clearly significantly lower with CABG, and the composite of death, stroke, MI, or repeat revascularization was also lower. When you use a different endpoint for myocardial infarction definition, the SCAI definition, you see that the event rate was 20% with PCI and about 24% with CABG. Now, looking at subgroup analyses, there was only one subgroup that has statistically significant interaction. That was based on Syntax score. Those patients with the low Syntax score, PCI, seemed to do better. Patients with intermediate, CABG did better. I wouldn't pay too much attention to the high Syntax group because this was a much smaller portion of the patients enrolled in the study. When we compare the 5-year outcome of FAME3 with the 5-year Syntax data, you see that the death, stroke, or MI rate was about the same in CABG, but PCI had gotten significantly better compared to what was seen in Syntax. When we look at death alone, both arms did a little better, or CABG, I guess, should say, did a little better. You can see that the PCI arm did dramatically better with respect to death. So we've also just recently presented and published quality of life and cost effectiveness data. At 5 years, there was no significant difference in clinically significant angina between the two groups. When you look at the quality of life based on the EQ5D summary index, not surprisingly, PCI had a better quality of life at 1 month, but by the time you get to 1 year and out to 5 years, there's no difference in quality of life. Interestingly, we also looked at patients returning to work. So we looked at the percentage of patients who are less than 65 years old who returned to work. Now, again, not surprisingly, at 1 month, it was significantly higher after PCI. But interestingly, even out to 5 years, there was a significant difference in the percentage of patients who returned to work. As far as the costs go, again, not surprising, there was a significantly higher cost with CABG early. And there was some narrowing of this over time due to repeat events, revascularization, and so forth in the PCI arm, but still at 5 years, the difference in costs was significantly higher after CABG. And so based on that, people feeling the same and the cost being higher, it's not surprising that when you look at cost effectiveness, in the vast majority of cases, the incremental cost effectiveness ratio for CABG was over $150,000 per quality adjusted life year gained, so not very attractive. I didn't show some of the other subgroups that we had looked at 3 years. But I highlight this because I think it shows some interesting groups of patients who benefit more from one treatment than the other. And you can see that most of them are benefiting more from CABG. So clearly the high syntax score. We also looked at the functional syntax score. About 50% of the patients had a low functional syntax score where they had similar outcomes. Women tended to have similar outcomes where men clearly benefited more from CABG. Diabetics, not surprisingly, more from CABG. Chronic coronary syndrome patients did better with CABG, whereas ACS, the differences were less. And quality of life, I mentioned, was similar, and cost was lower in PCI. So, of course, there are limitations, as we heard in the previous session, to every trial. We had a number of limitations. This was a pre-specified secondary endpoint of a study in which the primary endpoint was not met. So therefore, these conclusions are just hypothesis generating and need to be tested prospectively. The follow-up is only 5 years. We are pleased to announce that we received an NIH grant that will allow us now to extend follow-up to 10 years. So we're working on that. The study included relatively few women, Black, and other underrepresented populations. And I think most importantly, and this has been talked about by previous speakers, these analyses only apply to the type of patient enrolled in FAME3. So, there are clearly patients that have severe critical disease that weren't included that are getting bypassed. And that's why the STS registry has higher diabetics, higher patients with previous PCI, because those patients we know do better with bypass. So in conclusion, in patients with three-vessel coronary disease, there's no significant difference in the composite of death, stroke, or MI after PCI in comparison with CABG at 5 years. The incidence of death was the same. The incidence of MI was higher after PCI. And in a landmark analysis, there was no late accrual of benefit with CABG. These results differ strikingly from the syntax trial, where we did see a significantly higher rate after PCI, particularly with death, stroke, or MI, as well as death alone. So what are the clinical indications? The difference in outcomes at 5 years between PCI and CABG has narrowed, likely due to improved stent technology, the routine application of FFR, and greater adherence to guideline-directed medical therapy. Patients with lower coronary anatomic complexity based on the syntax score do better with PCI, while patients with greater complexity do better with CABG. The FAME3 trial hopefully provides contemporary data regarding outcomes after PCI compared with CABG, which can facilitate improved shared decision-making between physicians and patients. So I hope this is not going to be the result of the talk, and that this is what will be collaborative and work together. Thank you for your attention.
Thank you, Will. That was great. And before we open the discussion to the podium, I have just a curiosity. Explain me what is the rationale to go from a non-inferiority design at 1 year to a superiority design at long-term follow-up. And generally speaking, the reason to do that, and this is common, as you know, in most extension study, is because if you do not pre-specify your non-inferiority margin for the extended follow-up, then once you know the result of the early analysis, it just doesn't make sense. It's a conditional power exercise. But in that case, you guys did pre-specify from the beginning, not only the 1 year analysis, but also the 3 and the 5. So if there is a clinical rationale that I can very well see for an early non-inferiority design, what was then the reason to switch to superiority in 3 and 5 year? Thank you.
Yeah, so our hypothesis for the primary analysis was, as you just mentioned, non-inferiority. Our pre-specified secondary analysis, we hypothesized that CABG would be superior based on data from syntax, where death, MI, and stroke, it was superior, as well as death alone. And so we didn't power for it. And we would have had to enroll a lot more patients. We had limited funding. You know how, people who do these trials, you do them, you know how that goes. But that was the rationale. Yeah, so it was a practical decision. Yeah. In general, I believe that
the same clinical rationale that informed the primary analysis should inform the follow-up analysis, unless there is some mechanism that change over the course of the time. But I also understand what you're saying. Thank you. John.
Wonderful presentation, William, Dr. Fioran, and thank you for being here once again. We're delighted that you are part of the International Coronary Congress this year. Quick question about medical compliance, because it's something that has bothered me for a long time. In almost all prior comparisons of PCI versus CABG, whether they're randomized or registry, adherence to medical therapy is typically much better in the interventional cardiology group, in the PCI group, than in the CABG group. There are lots of reasons for that, but we also know that, especially more recently, as the impact of better medicines is more and more obvious and dramatic, it would seem to me that a difference in medical compliance between two limbs of a randomized trial could be pivotal to the interpretation of the results. You mentioned that compliance was pretty good, but you didn't break it out comparing the two groups. Can you do that for us?
Yeah, thank you. That's an excellent point, Dr. Puskas. And we were aware of that difference. And so in our investigators' meetings, we continue to emphasize the importance of achieving optimal medical therapy in both arms. And we looked and reported this in the Lancet paper. There was no statistically significant difference. Both groups received. The only difference, of course, as you'd expect early on, there was more antiplatelets in the stent arm because they got DAPT and the CABG didn't necessarily. But otherwise, statins, other medical therapies were similar. Yeah.
Thank you. Milan?
Milan Milojevic. Great presentation. Thank you so much. Sorry for misunderstanding this morning, because when I said spin, I was not thinking that something it's done which is not in the study protocol. I'm pretty aware of the study protocol. Actually, the slide from the FAME3 trial was a part of my PhD defense. So I also understand that you have a non-inferiority and then you move to the superiority design. But what I don't understand is that you don't have any statistical calculation for this superiority design, and then you claim equivalence between the PCI and the CABG. And in both the circulation and the Lancet paper, the last statement is that this data should provide more insights for the heart team decision making to the heart team. So I did some calculation, and in order to have this as a key, or have us as a secondary outcome, we probably need to recruit about 5,000 patients to claim the 20% relative risk reduction. So my message or my comment here is that we cannot really claim the equivalence in an environment where we have a very high risk of the type 2 error, because this can this can be very misleading, because 95% of physicians all around the world, they just read the abstracts and the conclusion of the paper. They don't understand the methodology behind, and this should be also acknowledged in the limitation, not only in the paper, but also on the slides.
Yeah, thank you for that comment. That's a very fair statement. I agree. I think I tried to emphasize that in my limitations, and we did the same in the paper, that this is, hypothesis generating. As you know, abstracts have limited word counts, and there's only so much you can include. We were strictly told by multiple people on our advisory board, surgeons, I will say, that we needed to include repeat revascularization in the abstract. So we can't include everything, but we included what people thought was the most important stuff. And I can't, I agree, a lot of people just read the abstract. We need to educate people that they need to read the whole paper, and they need to realize that this is just hypothesis generating.
Thank you. Faisal?
Well, great talk, Bill, and thanks for being here with us. I really, really appreciate it. And I can assure you there are no wolves in this room. They're all good German shepherds, and they're going to protect you. The wolves are the people that control the message. And some of them may be on editorial boards or journal editors. And Dr. Taggart shared with us a slide about Dr. Marcia Engel, I think, who was the cardiology editor of New England Journal of Medicine, who said that we can't trust trials or publications in high-impact journals because there's conflicts and the message gets some spin. So I'm not worried about you. You and I share it in our family history. My father had cabbage with a single mammary. Your father upped it by one. He's got bilateral mammary. So it's interesting to kind of learn about that today. And I know, talking to Joseph Wu, that you are a critical member of the heart team and you're very collaborative, and we really appreciate that. And you coming here means a lot to us. Now, you're going to get funded for 10 years. Now, that doesn't adjust for lack of power, because when you did your design, you had power based on a MACE that included repeat vascularization. So this extended follow-up will increase the event rate, but I don't think it's gonna be enough to overcome the power challenges. So I plead with you, please, to avoid the wolves. In the 10-year publication, in the abstract, mention the original primary outcome results in addition to the pre-specified secondary endpoint, and everybody will be happy. Thank you very much.
Yeah, thank you.
So we move to the next presentation after this very ecumenic discussion, and the next one is an update on the art trial by David.
So thank you, Mario. Thank you, everyone, for remaining so late in the day. We've heard a number of world-class presentations today, so we're very grateful to all the people attending ICC. Now, I'm going to start by disappointing you, because this was entitled Art Trial, 15-year outcomes, final results. And when we submitted this, we expected to have those outcomes for you, but rechecked by the statisticians, so that what we tell you is completely accurate. And we're about 1 month away from actually having them. So I can't do that today. What I will do, however, is go over some of what I think were the important lessons from the ART trial, and say something quickly about how I deploy arterial grafts, because this doesn't seem to be advancing but I'll try this. Right, okay, so I have no major conflicts of interest for this presentation, except I was the PI of the ART trial. We've heard several times in the literature recently, and at some of the presentations, that there seems to be a problem with the right mammary artery compared to the left, and this is simply not the case. This is a definitive paper by Jim Tutoulos and the late, great Brian Buxton, looking at what happens if you use right and left mammary arteries. If you put them to the LAD, the patency at 10 years is 95%. If you put them to the circumflex, slightly lower, but still 90%. And if you follow these patients out to 20 years, still over 90%. So if you're a group of surgeons saying that 25% of mammaries fail within a year, you're not doing the operation properly. But we must dispel any myth or concept that in some way a right mammary artery is inherently biologically inferior to the left mammary artery. It's simply not true. This is what happened in the ART trial at 10 years on the intention to treat mortality. We saw absolutely no difference. And when I saw this, I was disappointed, because to me, this was biologically counterintuitive. So I said to myself, I've been doing the operation for over 20 years. My crossover in the ART trial was 1.2% versus the trial average of 14%. So I said to myself, I'm going to ask the statisticians to look at my 416 patients on an intention to treat analysis. And if in my hands there's no difference in outcome, then the hypothesis is wrong. 2 mammary arteries are not better than 1. But when we did this analysis, and remember this is a smaller number of patients, obviously 416, but intention to treat. In my hands, with a 1.2% crossover rate, there was a strong survival advantage of the lateral ITA grafts. You can see that it begins to appear after about 4 years, but it's rapidly accelerating at 10 years. Now, I don't know any way I can design an operation where I don't want to see a difference at 4 years, but I want to see a difference after it. So this persuades me that in the hands of highly experienced surgeons, the hypothesis that 2 internal mammary arteries is better than 1 is indeed correct. And as I say, if you look at what's happening at 10 years, that survival advantage is accelerating, which is biologically plausible if we work on the basis that we know about 50 to 60% of vein grafts are either occluded or severely diseased at 10 years. Then this makes sense, because you cannot have occluded vein grafts and then say, but it doesn't matter in terms of completeness of revascularization. So to me, this persuades me that the hypothesis having 2 patent arteries in your heart at 10 years is better than having a single patent artery. If you looked at the ARC trial, we remarkably had 98% vital status at 10 years. But we did an as-treated analysis as well as intention to treat, because 40% of the patients received a different strategy from that initially proposed. 14% of patients allocated to beta actually got CETA grafting. And per individual surgeon, that crossover from beta to CETA varied from 0 to 100%. So some surgeons randomizing patients in the ARC trial were crossing every single one of their patients from beta to CETA. We also were not aware at the time we composed or constructed the ARC trial that the radial artery was a better graft than a vein graft. Mario has shown this very convincingly in several studies. So a lot of the patients who got single ITA also got the benefit of a radial artery. And as I say, when we constructed the trial, we didn't appreciate that difference. If we actually look at that as treated analysis, these patients, although not randomized, we compared those with a single arterial graft to multiple arterial grafts. And as I say, although not randomized, these patients were near identical for 20 baseline characteristics. We couldn't see any significant patient characteristics between these 2 groups. But what we then saw was, as you follow the patients out, looking at those who actually got multiple arterial grafts, a significant survival advantage beginning to appear after 2 years and accelerating again at 10 years. And this is very similar to the data produced by Joe Sabick and colleagues of their 1 million patient analysis of patients who actually got a single versus multiple arterial grafts. That at 10 years you see this survival advantage that continues to accelerate. I've got 4 minutes left, so in the last couple of slides, I just want to show, because the most common question I ever get asked is, how do you deploy arterial grafts? This is all published, so it's not just an opinion piece just now. So the first thing I'd say is we do skeletonize mammary arteries. I know about the controversy about them, but it makes composite and sequential grafting easier. Do not harvest the distal 2 centimeters of the ITA. You never need it, and it is more spastic. You can see it with your eyes. And Dr. He in China has repeatedly shown that in laboratory testing, that last 2 centimeters of mammary artery is much more prone to vasospasm. And as Mark Gruelle said yesterday, maybe the reason the right mammary could be worse is people are harvesting the full length, because often it's not long enough to do what you want to do with it. You should divide and clip the lita after you've harvested it. You do not need to heparinize, and if you do heparinize, all it does is make harvest of the right mammary artery more difficult, because everything oozes. And all you need to do, I made this point yesterday, you do not need to give any vasospastic agents unless you consider what you do ask your anesthetist to do is get the blood pressure to 150 millimeters of mercury for 5 minutes with a clipped mammary artery, and it will double in size. And if you haven't tried it, please do. And if you ever get a mammary artery that clots, you can sue me for having given you false information. But this is published. It's the only artery in the body that will not clot. So if you're looking at graft selection for arterial grafts, there are actually 9 considerations. So I'm going to go through them very quickly. You need to decide, are you using single, multiple, or total arterial grafting? What is your best second graft? if you're experienced it's the right internal thoracic artery, unless you feel the patient's at higher risk of mediastinitis. We generally use Rita, and radial for the best left-sided vessels. Competitive flow is a real risk for arterial grafts, especially for the radial artery. If you're doing, you then need to decide how many left-sided distal anastomoses you need. If it's only 2, most of you can do with incisor grafts. If it's more than 2, you need to do composite grafts, and you need to be aware in about 10 to 15% of patients, the Rita will not comfortably reach the LAD. In my practice, and for a long time, every composite graft we do is a T graft. If you do patients off pump, you can think you've got a perfect Y anastomosis until you put the heart back into the chest, and then it doesn't look so good, that anastomosis alive it. Whereas if you've done it as a T graft, it's not a problem. If you've got a conduit problem, then remember saphenous vein graft is your best friend, and a good saphenous vein is always better than a bad arterial graft. And there are ways you can improve the outcome of those veins. No-touch harvest technique. As Dr. P-Bong Kim has shown us, if you use it as a composite graft from the ITA, and there's very good evidence that external stenting can reduce disease progression in vein grafts. For us, for off-pump surgery, always do your occluded vessel first, but we will then generally do the graft to the lateral wall, put the heart back in the chest, and then do the, well, I'll show you an example, but we'll then do sequential grafts. Now, what's quite important here is this is the simplest way, in my opinion, to do 2 mammary arteries, if the right is long enough to do it and you only need 2 grafts. It's conceptually and technically very straightforward. 10 to 15% of cases, your Rita is too short, and also some surgeons feel hesitant about having a Rita cross the midline. So to me, this is the best way to do arterial grafts. I've tried to do it every single way over 3 decades. And to me, the best way to do it, if you need 2 or 3 distal anastomoses, is Dr. Barner, the great Dr. Barner, previously taught us to take to take a Rita graft, and you only need, by taking the Rita graft, you only need 2/3 of it. You rarely ever need the full length of a Rita graft. And he taught us to put it to the lateral wall of the Rita. I would suggest completely opposite, and in my experience, the simplest way to do this operation is bring the Rita from the medial side of the Rita around the second intercostal space. And then what you do, as off pump, you do your Rita to the best obtuse marginal vessel, and then you can put the heart back into the chest. And you then get this lie of the Rita coming from the medial wall of the Rita. It's a perfect lie. It's technically very easy to do, and it never kinks. And that, in my opinion, is a way to give you your 3 best left-sided anastomoses. Now, I'm 1 minute 50 over, so I'll stop there at that point. But I have made most of the points I wanted to make this afternoon. So thank you to the organisers. So that's me as well. And thank you, the audience, for your attention. And let me very quickly say, the great work done by Jan Luca, Torsten Dunst, and Faisal Pakin, they have significantly elevated the quality of this meeting. So very well done.
I'm going to interrupt for just one moment, because I know that Dr. Naresh Chauhan has to go next door to moderate another session in the other arena. But I think many of you know that our 12th annual International Coronary Congress will be held in the same place that we held our 2nd annual Coronary Congress, New Delhi. And we're very, very happy about that for a variety of reasons. One of them is because India is the nation that now performs the largest number of coronary bypass operations of any country on earth, and is growing more rapidly in volume than any other country on earth, and is arguably as innovative as any nation on earth. Moreover, we have a dear, dear friend and ally in improving coronary care, who also happens to be in charge of an enormous medical industrial complex that he created himself in India. And he will, I'm sure, again host us in grand fashion in New Delhi, November 20 to 22 next year. So we're grateful to Dr. Trehan. I wanted to let everyone know that that's where we will convene next year. Dr. Trehan.
To extend that invitation to everybody in this room. And it's going to be a big meeting. I think there'll be more than 1,000, 1,500 cardiologists, surgeons, everybody there. So I think it'll be worthwhile, and a lot of discussions can carry on next year. We'll put some of our own data out, the Indian data out there so also for discussion. So most welcome, all of you. Thank you.
So I will introduce our next speaker, who literally needs no introduction, Dr. Gaudino. And interestingly, his title is provocatively named Radio Gaudino. But for any of us who've looked at what's happened, certainly over the last 5 years and before, Mario is unquestionably the most proliferative writer and publisher of evidence-based cardiac surgery. So I'm sure if anyone can give us this update on ongoing trials, we couldn't have a better speaker than Mario. So thank you, Dr. Gaudino.
Thank you, David. That was far too nice. And I must confess, when I received this invitation, I didn't understand what Radio Gaudino meant. So I called John, and I said, what exactly do you want me to talk about? He said, well, just say what kind of trials you are leading and what's happening in the next few years. So I said, okay, fine, I think I can do that. So I will just give you a brief summary of where we are with a number of trials that I think will affect the profession in the next few years. And clearly we start from the first trial that was where we started in 2017 with Steve. It's the Roma trial. I think we all know this is it's not a conduit trial as ART was. This is a strategy trial. So single versus multiple arterial grafting. In a multiple arterial grafting arm, the use of both the radial artery or the right internal thoracic artery are allowed in any configuration. It is a large trial of over 4,000 patients, and the primary outcome is a classic MACE composite outcome with the exclusion of perioperative myocardial infarction, a decision that was made because of the issue and the challenge in defining clinically significant perioperative myocardial infarction. If we put Roma into context, it's a very large trial. There has been only another cardiac surgery trial that has been largest than Roma. It's coronary. Coronary, however, had a shorter follow-up. So if we adjust the sample size for the length of the follow-up, Roma is definitely larger. We enrolled 4,375 patients over the course of 3 years. We concluded enrollment in March of 2023. Now, Roma is an event-driven trial, so we will do the analysis when we reach the number of events that allow us to perform an analysis with adequate statistical power. So where are we with the accrual of the event? This is where we are. We are at approximately 60% of the event. 500 of the 800 events have accrued so far. So our projection is that the primary analysis will be performed probably in 2028. It's possible that it will happen earlier if there is an acceleration of the event rate. We do generally anticipate an acceleration of the event rate with the extension of a follow-up, but if this is not the case, we are looking at 2028. Now the spin-off, like in the TV series of Roma, has been Roma Woman. The first cardiac surgery trial in women is essentially the same protocol or very similar protocol to Roma, but this enroll only women, 2,000 women. We were supposed to enroll 2,000 women in 5 years, and we have enrolled them in 2.5 years. The sample size was 2,000 at least, 2,000 patients. That was reached a few weeks ago. However, we have funding from several European funders. This was a collaborative funding mechanism through GCRFF. And so there was a request to keep enrollment open to meet national goal, because we haven't seen any risk. It was the two interventions that are standard of care that was approved. And so we will keep enrolling for another 6 months. Roma women is slightly different in the primary outcome, and also is not an event-driven trial. So probably the result will be in 2029. So between 2028 and 2029, we will have the result of both trials. Now, something that is interesting to note when we compare Roma to Roma women is that in terms of conduits, those are different trials. Roma, not by protocol, but by chance, is a 50-50 split between the right internal thoracic artery and the radial artery in the multiple arterial grafting arm. Whereas in Roma women, the radial artery dominate, which is not surprising because of the issue of using bilateral internal thoracic artery in women. So Roma women will be more a radial artery trial, and Roma will be a combination of bilateral internal thoracic artery and the radial artery. This is just a randomization by country, with China, United States, and Canada dominating, and then all the other European countries. Another trial we are very excited about, and that has started approximately a year ago, is the ODIN trial. This trial is looking at short-term dual antiplatelet therapy after CABG. We all know that currently guidelines do recommend aspirin for all CABG patients, and in selected patients, but how selected is unclear, dual antiplatelet therapy. And the reason for that is actually in the individual patient data meta-analysis that Sigrid published a few years ago on JAMA, pulling the 4 randomized trial that tested 1 year of dual antiplatelet therapy after CABG. And the result were that dual antiplatelet therapy for 1 year does improve patency, however, at the cost of an increase in bleeding episode. The problem is, why are we using 1 year of dual antiplatelet therapy after CABG? And the answer is, well, because this is what we do after PCI. But PCI and CABG are different. We don't have a drug-eluting stent. The endothelium will heal much faster after surgery, after the PCI, because we don't have a drug that is designed not to allow the endothelium to heal. So we believe that a much shorter course of dual antiplatelet therapy can protect our graft without increasing the bleeding risk. And this is essentially the rationale of this trial, that is testing 1 month of dual antiplatelet therapy after CABG and its effect on a composite of cardiovascular event and graft patency. And our secondary aim is to determine the net clinical benefit, so to see if this short treatment course does not increase, as we suspect, the risk of bleeding. This is just a flow of an ideal patient in the trial. Clearly, there is an assessment of eligibility before surgery, but there is also another assessment of the eligibility after surgery. Patients who experience major postoperative complication cannot be randomized, but patients who have a smooth postoperative course are randomized to ticagrelor DAPT for 1 month or aspirin. After 1 month, everybody's on aspirin, and then we do a CTA at 1 year for patency. It is a relatively small trial, 700 patients in several countries. We have started enrollment less than a year ago. We are already at 400 patients, and we anticipate to complete enrollment by the spring. Then there will be 1 year follow-up and the CT scan, and then we will see if this short course of DAPT can actually improve patency without increasing the bleeding risk. Another trial we are doing together with the Hamilton team, Rich Whitlock and Emily Bellicote, is the confirmatory trial of the left posterior pericardiotomy. In a single center trial at Cornell, we have shown a very large reduction in the risk of atrial fibrillation with this very simple maneuver. It was a mechanistic trial with very selective inclusion criteria, and it was single center. So now we design a larger confirmatory multi-center trial. We are not only looking at if pericardiotomy reduced postoperative AFib, but also if this early reduction in postoperative AFib reduced the rate of cardiovascular events during the follow-up. So we have an early co-primary outcome and the late co-primary outcome. It's a trial that is enrolling incredibly fast. We have started a few months ago, and we have already enrolled over 600 patients. Enrollment will be completed by the summer, and the primary analysis, we are targeting ESCTS in October. And then finally, this is the baby of the family, Smart Flow. This is a trial testing finally the TTFM hypothesis. It's really not a trial, it's a trial program. There is a family of trial that are looking at TTFM in different patient population. This is the first child, is a Smart Flow patency. We are testing the use of TTFM and on graft patency. Graft patency is assessed by CTA very early, 1 to 3 months after the intervention. We will collect also MACE data, but we are not, and also quality of life data, but we are not powered for MACE. If the patency data are positive, then we will keep enrolling, and we'll have a larger trial where we will compare clinical outcome at 5 years. So this will be the vanguard phase of the larger clinical trial. If this is neutral, there is no reason, obviously, to do a larger trial. And we are also designing a Smart Flow in women who have a higher risk of technical failure and technical complication during the operation. Smart Flow, it's a pragmatic trial, nothing change except randomization and the CTA at 1 to 3 months. It's an experience-based trial, so surgeon can perform only the TTFM operation or only the not TTFM operation or both, depending on their experience. And the first patient in this trial will be randomized at Cornell next week. And again, my pets. Thank you.
Mario, as always, excellent presentation. John, you.
Brilliant Radio Gaudino. It's like a Radio Free Europe for coronary investigation. So thank you. But also, I want to thank you, Mario, for 3 years of having been our Secretary, Treasurer, and Program Chairman. No one has lifted this organization more than Dr. Gaudino, and we're really honored and happy that he's still part and able in his unbelievably busy schedule to contribute to this annual meeting as well. Thank you, Mario.
It's my honor.
We have time for one question, if anyone has one. So my question is, why is Mario only doing 4 new randomized trials?
I got lazy lately. You're right. I could do more. I could do better.
Okay, I don't. Did somebody have a question or? Yeah, please.
Maybe I saw it not correctly, but I was a little bit concerned about the Roma trial slide that you showed that at 19 months, maybe I didn't see correctly, but there were less than 60 patients at risk, starting from 4,000, but I didn't see correctly. But
19 months is essentially 7 years, 8 years. That's when we started enrollment. So that's actually totally correct. I mean, the number, the patients who have 8-year follow-up are very small because we started enrollment 7 years ago.
Okay, thank you.
Thank you. I'm embarrassed to say I don't know who our next speaker is because I don't have a program. Thank you. Okay. So this presentation by Dr. Salna, safety of concomitant ascending aortic aneurysm repair at the time of coronary artery bypass grafting. Thank you.
Thank you very much. My name is Michael Salna. I'm an aortic surgeon at NYU, and it's pretty cool to be presenting here. I was here 2 years ago as a resident, so thank you very much for the invitation to present. So today I'm going to be talking about the safety of performing concomitant elective ascending aortic replacement at the time of elective CABG. So the null hypothesis here is that adding a prophylactic ascending aortic replacement to a cardiac operation does not increase the risk when aortic disease is not the primary indication for surgery. Is that right? Well, the current evidence, because I don't want to give any spoiler alerts, would seem to suggest yes. The largest paper that addressed this was one from the Cleveland Clinic that looked at 647 matched pairs of cardio-aortic patients. So these are patients that had non-aortic cardiac surgery and an ascending aortic replacement, and those were matched with patients that had the same cardiac operation only. Notably, though, 50% of those ascending patients had circulatory arrest, and there was quite a big case mix diversity in the types of cases that were looked at. So only 28% of them had CABGs, 25% of those were re-ops. And the results were excellent. There was no significant difference in death or stroke. There was a significantly higher rate of prolonged intubation, atrial fibrillation, and dialysis, as well as length of stay, but overall the results were great. So if we now scale that to sort of the rest of us mere mortals and look at the STS database for the North American experience, we looked at patients that had a principal indication for elective CABG alone. So that was defined as patients that had either triple vessel disease or left main disease from 2014 to 2023. And there were 373,000 of those, close to 374,000. And then we picked out those that had only ascending aortic replacement, which was actually a little bit tricky to parse out. For anyone who's looked or done any STS database projects, it's not always clear. Well, anyway, I'll just leave it at that. There's a big disparity in kind of the different versions, and so these are patients that had no circulatory arrest, they weren't cooled to less than 24 degrees, and they all had clamped distals. So I felt that that was a reasonable way of isolating only those who had ascending replacements without any cerebral perfusion, et cetera. And there were only 833 of those. And again, none of those patients had circulatory arrest. So the first conclusion is that ascending aortic replacement is not common. Only 0.2% of the cases of, again, elective CABGs had elective, so not dissection or anything like that, ascending aortic replacements. When we look at the demographics, we can see that the aortic patients were more likely to be male. They were slightly older, skewing towards more septuagenarians. They were less likely to have diabetes, more likely to have peripheral arterial disease, less likely to have MI, and less likely to have had dialysis. Intraoperatively, not surprisingly, these patients had longer OR times, bypass times, and clamp times. But so, again, we get back to our hypothesis, which is that adding a prophylactic ascending replacement to elective CABG does not increase risk when aortic disease is not the primary indication for surgery. Well, actually, that turns out to be wrong. There's a significantly higher rate of death. There's a significantly higher rate of reoperation for bleeding, stroke, prolonged ventilation, renal failure, and combined morbidity and mortality. Now, there are STS scores, of course, for isolated CABGs, but they don't yet exist for combined CABG aortic cases. That actually is slightly changing now that there is an aortic risk calculator out, but at the time of the study that did not exist. So we used one of the STS-approved vendors to actually go back and calculate STS scores for all of those combined patients as if they only had CABGs. And what we found is that the observed rate of complications in these patients was actually double the predicted risk as if they had CABG alone. So again, double the rate of death, double the rate of reoperation, stroke, prolonged ventilation, renal failure, and combined M&M. So if you remember earlier when I showed the demographic slide, there was quite a few significant differences between the two groups. So we propensity matched them. And yet again, even in propensity matched cohorts, these differences still persisted, with significant differences in almost all of the STS complications. We then performed logistic regression for predictors of mortality in the cardioaortic patients. And again, given this relatively small number, the variables that you see here, there were only 3 in univariate analyses that were significant. That was age, peripheral arterial disease, and cerebrovascular disease. High volume center we forced into the model just because that's always kind of a relevant question people ask. But that was defined as only 5 cases because most centers only did like 1 or 2 of these a year. And age and peripheral arterial disease were significant. So this study, of course, has significant limitations. Unfortunately, the aortic size data was largely incomplete and unavailable. So it's difficult to know at what size aortas surgeons were operating on. Similarly, we don't know what size aortas were being left behind and the natural history of these patients. So, you know, if you were to leave behind a 5.1 centimeter ascending aorta, what is the natural history of that patient with several proximals, cannulation sites, tack sites, et cetera? There is an unexpectedly low incidence of concomitant ascending aortic surgery. Now, I do think that in light of lacking the size data, that this probably underrepresents the true extent or true burden of aortic disease in these patients, just because we didn't have the size data. Moreover, I excluded over 2,000 patients that had concomitant arch or root surgery. I suspect, though, that in those cases, the complication rates would be even higher. And again, when I presented that data on high-volume centers, that was high-volume CABG centers. So because we didn't have all of the aortic data, I can't comment on high-volume aortic centers and whether their data are different. So in conclusion, the addition of elective ascending aortic replacement to elective coronary artery bypass grafting has incremental risks. And obviously, it's important to share those risks in decision-making with patients. Now, that's not the most glamorous or useful practice-changing statement, but what I do think is relevant and perhaps in the future impactful is how this affects the current and subsequent future aortic guidelines. So in 2022, the ACC-AHA revised the aortic guidelines. And actually, the text looks a lot smaller on my screen. I'm happy it's bigger there. But in the 2010 guidelines, concomitant aortic surgery you would tend to do at 4.5 centimeters, and there's still a lot of surgeons that practice that. Over the course of the subsequent 12 years, the guidelines were changed to maintain 4.5 centimeters for an aortic valve replacement, but for every other operation, so mitral, CABG, myectomy, et cetera, that's now 5 centimeters. And of course, now there's also the inclusion of a multi-center or multi-expertise aortic team. I do think that, again, what this paper or this study should demonstrate is that not every type of cardiac operation is the same, and we shouldn't paint all these people with the same brush. So hopefully moving forward, new guidelines will kind of incorporate different permutations of operations to better treat our patients. So just want to acknowledge the STS for their help with all of the data, and thank you so much to everybody for your attention and invitation.
I think your conclusion is wrong. You
Perfect.
have not really shown that the addition of an ascending aorta replacement increased the risk. You have shown that the patient who need ascending aorta replacement have increased the risk. This is a very important difference in between the two. In non-randomized study, the patient population are intrinsically different. You can propensity match to the wazoo, but there is just a number number of variables that you do not capture, so you're not comparing the same patient population. So patients who need an ascending aorta replacement of a different disease, a different severity of disease, a different type of disease compared to patients who do not need ascending aorta replacement, and they have higher operative risk, which is interesting information, but there is no causal link between the two. And so that's why the guidelines are not going to change based on non-randomized data and appropriately. So I think it's important to keep that in mind, because in surgery we keep doing a non-randomized study, and then we want to make inference that should be applied, in our opinion, to guideline, but that will never happen because of what I'm just describing.
Yeah, that's a good point. Respectfully, I actually disagree with that, though, because since we didn't have aortic size data, we don't know how many of those CABG patients that did not have ascending replacements did have some semblance of aortopathy. So on the flip side, it's
probably no one.
We don't.
Well, you know,
that's the issue, is that we don't know.
No, you don't know, but you know that from the very first beginning of your training, you was trained to adapt the operation to the individual patient in front of you and to do the best operation for that specific patient. So your decision to replace or not to replace the aorta is based on clinical consideration. It's not a random decision. If it was a random decision, then non-randomized study could be important even for inference evaluation, but that's not the case in surgery. In surgery, there is always a reason why a surgeon decides to do one operation or the other, and comparing different operations with using non-randomized data essentially means exactly as in this case, comparing different patients. So it's a natural history study, but there is no comparative effectiveness part in it.
Okay, thank you for your comment.
Yes.
Hello everyone, I'm Alexander Jacquemin. I'm a research fellow at the University of Pittsburgh Medical Center. I have one question. So all of these patients were isolated CABGs, but as you said, you do not have the data on how large their aortic diameters was. So you're not filtering out any patients who could potentially in the future have an aortic intervention, right? That is the group you're interested in. You want to compare those, because those are at higher risk of getting an aortic intervention in the future.
That's exactly right. So that's a huge limitation, is that we don't have the size data, so you can't make any inferences on the natural history. What I can tell you is that doing an ascending replacement in a re-op after a prior CABG, because the surgeon before did not replace the aorta when it was 4.7 or something like that, is quite a more challenging case. So, yeah, lacking the size data was a big limitation.
Thank you very much. Thank you. So the next speaker is John Alexander, who needs no introduction, and he will give us an update on PACES.
Great. Thank you, Mario, and thank you, John Puskas and David Taggart, for inviting me to this. I'm going to give you, I'm a non-interventional cardiologist. I work at Duke, and I'm going to give you a quick update on the PACES trial, which is investigating therapy for the most common complication of cardiac surgery and coronary artery bypass surgery, that is postoperative atrial fibrillation. So these are just my disclosures. PACES is funded by the National Institutes of Health through the CT Surgery Network. So atrial fibrillation is the most common pathologic arrhythmia, and its incidence increases with age. There are tens of millions of Americans who have atrial fibrillation. Atrial fibrillation, it causes 20 to 30% of all strokes. And the strokes related to atrial fibrillation are particularly severe and disabling and tend to be large. Atrial fibrillation is also associated with heart failure, hospitalization, reduced quality of life, and death. However, fortunately, atrial fibrillation-related stroke can be effectively prevented, like preventing more than 70% of strokes related to atrial fibrillation with oral anticoagulation. So this is an overview of anticoagulation for AF stroke prevention clinical trials over the last several decades. In the 1990s, there were 6 small trials, including a total of 2,900 patients that randomized patients to Coumadin, warfarin, a vitamin K antagonist, or placebo, who had atrial non-valvular, non-mitral stenosis-related atrial fibrillation, and showed that warfarin reduced stroke by 64% compared to placebo. In the years from 2009 to 2013, there were 4 new drugs, collectively referred to as the NOACs, or direct oral anticoagulants, that were compared with warfarin that further reduced stroke by 19% overall compared to warfarin. These two together mean we're preventing more than 70% of strokes related to atrial fibrillation in appropriately anticoagulated patients. Now, as I go through this, it's really important to remember when you're studying anticoagulants or other antithrombotic drugs that there's always a trade-off between reducing antithrombotic events and increasing bleeding. And all effective antithrombotic drugs increase bleeding. Perioperative atrial fibrillation is the most common complication after cardiac surgery and occurs in 20 to 40% of patients, depending on the population and how you define perioperative atrial fibrillation. Its typical onset is 1 to 3 days post-op. It's usually self-limited and resolves by 2 to 4 weeks. There are numerous modestly effective methods for preventing postoperative atrial fibrillation, and postoperative atrial fibrillation is associated with all kinds of bad outcomes, both short and long term. A recent study looked at the incidence of atrial fibrillation very systematically in 198 patients undergoing bypass surgery. They all had loop recorders implanted, and the overall, for a year after surgery, the overall incidence of perioperative atrial fibrillation was 48%, so half of patients had some perioperative atrial fibrillation. Most of it was clustered early in the days and weeks following surgery, with much lower incidence later on, and no patient who had postoperative atrial fibrillation out of these 200 developed atrial fibrillation-related stroke. So the current guidelines have from the American Heart Association, American College of Cardiology, recommend that anticoagulation is reasonable to use for postoperative atrial fibrillation. In 2014, they had a 2A recommendation based on level of evidence B and stated it is reasonable to administer antithrombotic therapy in patients who develop perioperative atrial fibrillation as advised for non-surgical patients. In 2013, these were updated to say in patients who develop postoperative AFib, it's reasonable to administer anticoagulation when deemed safe for 60 days, and then to reevaluate the need for longer-term anticoagulation at that time. This later recommendation was based on a meta-analysis of 8 observational studies that included 15,000 patients and 5 years of follow-up. It's noteworthy that the recommendation recommends short-term anticoagulation, even though these patients are at high risk for adverse outcomes long-term. And it's entirely, as we just had in the last discussion, these are observational studies. We don't know whether anticoagulation from these actually improves outcomes. I'm just going to skip that. So with this background, the NIH-funded CT Surgery Network investigators talked about studying anticoagulation in patients with perioperative atrial fibrillation. We were initially interested in comparing DOACs with warfarin as oral anticoagulation for postoperative atrial fibrillation. However, in our discussions, we realized whether oral anticoagulation is beneficial at all is unknown. And currently, significant variation exists in clinical practice in the use of oral anticoagulation for post-op atrial fibrillation, and current guideline recommendations are based on really weak evidence. So we designed the PACES trial. The objective of PACES is to compare the effectiveness, that is the prevention of thromboembolism, and safety on bleeding of an oral anticoagulant strategy versus a no oral anticoagulant strategy in patients undergoing isolated CABG surgery who develop postoperative atrial fibrillation. This is a slide of the design. It's a very simple strategy trial. We monitor patients who are undergoing uncomplicated isolated CABG surgery who have no history of atrial fibrillation. We look for those who develop postoperative atrial fibrillation, and then they're randomized 1-to-1 to an oral anticoagulant-based strategy or a no oral anticoagulant-based strategy. The planned sample size is 3,200 patients. Now, very important, we wanted antiplatelet therapy to be similar in these two arms. So prior to randomization, patients have planned antiplatelet therapy with either aspirin or a P2Y12 inhibitor, clopidogrel or ticagrelor, but not dual antiplatelet therapy. And we wanted this because we wanted to avoid patients getting randomized to triple therapy in the anticoagulant arm with aspirin, a P2Y12 inhibitor, and an oral anticoagulant. And we wanted the antiplatelet therapy to be similar between the two arms. This is a schematic of the flow of patients in PACES. Again, isolated CABG, development of postoperative atrial fibrillation, randomization to oral anticoagulation or no oral anticoagulation for 90 days until their primary effectiveness outcome, which is a composite of death, myocardial infarction, stroke, transient ischemic attack, or venous thromboembolism. At 90 days, they transition to standard of care. One of the really interesting questions in designing this trial is how long do we anticoagulate people given that the postoperative atrial fibrillation is all gone by 30 days. And so we're going to continue following people for another 3 months to 180 days to see what happens with thromboembolic event rates. As I said, the primary effectiveness endpoint is death, stroke, TIA, MI, or DVT or pulmonary embolism. Our primary safety endpoint is BARC type 3 or 5 bleeding. Our planned sample size is 3,200 patients. This is based on a projected incidence of 6% of the primary effectiveness endpoint by 90 days in patients not receiving oral anticoagulation, and a 40% reduction to 3.6% in people receiving oral anticoagulation. This is a big treatment effect, but remember the treatment effect of oral anticoagulants in non-surgical related atrial fibrillation is more than 70%. So we think we should have adequate power. And so we have 85% power with a two-sided p-value of less than 0.05. Our current status, we have more than 100 sites open in the United States, Canada, Germany, the UK, and Brazil. We have more than 2,600 out of our planned 3,200 enrolled. There have been formal interim analyses at both 50 and 75% of enrollment reaching 90 days by our Data Safety Monitoring Board, and they have said continue the trial as planned. We've been very clear with the DSMB that we need an answer in this trial about both bleeding and thromboembolic events. We think we'll finish enrollment next year and have results in 2 years, and so I won't be able to present them in Delhi, but the following year I could probably present the results here. Thank you. So in conclusion, post-op AFib after cardiac surgery is common, very common. If you look for it, it occurs in half of patients. We don't currently have good evidence on how to treat it or know whether it matters long-term. It's certainly associated with long-term outcomes, but we don't know that treating it improves those outcomes. The potential PACES results, oral anticoagulation will almost certainly increase bleeding. There's no real way it cannot increase bleeding given what we know about oral anticoagulation. It's very unlikely that oral anticoagulation will result in more thromboembolic events, but we really have no idea whether it will result in similar or fewer thromboembolic events. And irrespective of the results, PACES will answer the question of whether oral anticoagulation offers a favorable risk-benefit profile in patients with postoperative atrial fibrillation after cardiac surgery and will change guidelines and practice. So I want to thank the NHLBI, the CT Surgery Network, all the PACES site investigators and obviously coordinators, the CTSN Data Safety Monitoring Board, and all the patients who participated in PACES. And then I think a little humility is good, and this is a quote I like from Lucius Seneca, who lived around the time of Christ. It's a good thing that we live in a time when medicine has made such progress. Thank you.
Thank you, John. That was wonderful. This is really a seminal trial. We are all looking forward to the result, and it's finally happening. I think I grew up with SPACES. I remember
Yes.
that SPACES has been happening.
It's been enrolling for a long time. I wish we had some of the problems of your trials of enrolling too fast, but we're getting there.
It's a challenging trial. Any question for John? Thank you, John. So our next speaker is Dr. Hristo Kirov from Jena, investigating the effect of invasive treatment of coronary artery disease in the elderly. Thank you, Hristo.
Thank you, Mario, dear Chairman, ladies and gentlemen. It has been already presented here that cardiovascular disease is the leading cause of global death, but what is important is 1/3 of all global deaths are due to cardiovascular disease, and most importantly, the majority are due to heart attacks or stroke. What we probably don't know is that age is the strongest factor that is connected with the development of coronary artery disease, and here in the United States, about the majority of the myocardial infarctions occur in patients that are older than 65 years, and 1/3 of them older than 75 years. And adding up to that is that not only the older patients have more myocardial infarctions, they are also more deadly in the elderly population. So we can conclude that elderly patients are at increased risk of MI-related death. And what we also know that coronary artery disease has two presentations. We have non-obstructive coronary artery disease, which we have a vulnerable plaque which can rupture and cause an occlusion, a myocardial infarction. Or we have obstructive coronary artery disease, which slowly progresses and can also occlude the vessel and cause a myocardial infarction. And as already presented multiple times here at this meeting, the majority of myocardial infarction come from non-flow limiting lesions, which are vulnerable lesions, and only a small percentage come from the second. And as we also have commented multiple times, coronary bypass grafting prevents the occurrence of new myocardial infarction by bypassing most of the collateral lesions, that collateralization effect, which already spoke numerous times. So to wrap it up, coronary artery disease limits life expectancy, specifically in the elderly, by myocardial infarction deaths, and CABG may effectively prevent those myocardial infarctions in patients with complex CAD. So this is also, you can find that in the guidelines with 1A recommendations for CABG, but in older patients, contrary to the recommendations, PCI is normally the preferred recommended therapy due to its lower invasiveness, and even if the anatomic complexity would favor bypass grafting. And the reason for this recommendation is based on the perception that CABG carries higher surgical risk in those older patients, and also coming to that is also that patients that are old are also frail. As you can see, the previous European guidelines have a clear recommendation that PCI is favored in advanced age and frailty, and so in older patients, PCI is currently the preferred therapy due to its lower invasiveness, and the reason for this is the surgical risk, but the evidence that we currently have does not support this perception. So there is a complete lack of evidence. As you can see, the latest guidelines say that in making treatment decisions, we have to think there's limited external validity of RCTs for older adults. Normally, they are not included in randomized trials. They're underrepresented, and of course, you have to consider frailty. What we see from the observational data is a meta-analysis that we did is that CABG has the ability not only to normalize life expectancy in the elderly, but you have a better life expectancy compared to the general age and sex-matched general population if you are older than 70 years old, if you survive CABG. And also for octogenarians, you are compared to PCI, they have better long-term results. As age there is biological age and not only numerical age, and older patients are often frail. And we can also see that even for frailty, and this is results of the randomized fragile trial from Brazil, where they compared off-pump to on-pump, but irrespective if you operate off-pump or on-pump, you can see a dramatic decrease of the frailty status after 6 months after bypass surgery. If patients are pre-frail or frail. So CABG improves frailty significantly. And currently, we don't know, in a comparison between PCI and CABG, there is no randomized comparative of those two invasive therapies. They have never been assessed what happens with either of those. And such data are urgently needed. As current recommendations are based more on beliefs and individual opinions and not of the facts. So that's why we wanted to do the CABG-1 trial. That's what we named it. It's a randomized assessment of frailty in elderly patients with coronary artery disease that undergo bypass surgery or PCI. Based on the power calculation from the fragile trial, we calculated that in a single center we would need around 100 patients. We want to randomize 1-to-1 ratio to a treatment either with PCI or CABG. Patients that are more than 75 years old, pre-frail or frail, we want to use the free frailty criteria for that, and of course are eligible for both therapies. Those are the exclusion criteria. And we want to follow up or include patients that have at least 3 years of life expectancy. Our primary outcome would be difference in frailty status that's assessed using the free frailty criteria at 6 months, and of course the standard secondary outcomes that are typical for most cardiovascular trials. We will follow up the patients at 6 months for the primary outcome and a minimum of 1 year interval of post-intervention. We'll do frailty assessment, clinical examinations. This is our work plan, and we have secured funding from our local institutions for the first part of the trial. We are planning to start next year and hoping after completing the CABG-1 trial to be able to get funding for a second part, which is moves away from frailty as a primary endpoint and goes to more hard clinical endpoint as mortality and myocardial infarctions. And there we are planning to get the endpoint that is in the FAME3 and syntax trial as a composite endpoint. Thank you for your attention.
Thank you, Risto. Any question? Are you stratifying randomization by decades, for example? Because I guess that a 71-year-old patient is old, but not as old as an 88-year-old patient, and in a 100-patient randomized trial, even a small imbalance between those characteristics can actually drive the result of the trial.
We didn't plan a stratification, but what is important, we need equipoise between the two therapies. So if the surgeon or the interventionist both believe that this patient is treatable by both therapies, we wanted to include them. But this is a very significant point that we probably would have to consider and address before we start the trial.
Thank you for your very nice presentation. How are you going to perform CABG? Is it going to be off-pump, no-touch aortic technique?
Yes, that is the primary way that it's a single center trial in the center where I work, and the majority, over 80%, are off-pump, no-touch aorta.
Thank you.
Any other question? Thank you.
Thank you.
So our last speaker is Dr. Holfeld, who will discuss cardiac shock wave therapy in addition to CAB to improve myocardial function in ischemic heart failure. Thank you.
Thank you very much. Thank you for the organizers to having me. I'm really happy to present the results of the CASTIGE-F trial that we published last year in the European Heart Journal. It's actually the first time outside of some grand rounds that I'm presenting this trial at a meeting in the United States. CASTIGE-F means cardiac shock wave therapy in heart failure patients, and this is what my research group and I was working on for almost 20 years. We started with basic research and finally made it to clinical application. I have a significant conflict of interest because I'm a co-founder and also shareholder of the university spin-off company that today provides the devices that you will see in a second. So don't want to stress that too much, but you all know that CABG is class 1 indication in European as well as US guidelines for the revascularization of patients with reduced ejection fraction. We've seen that today many times, that we know from large trials that there is hardly any relevant effect of ejection fraction improvement after revascularization. And the background is that, or this is the reason why regeneration of ischemic myocardium is urgently needed for clinical routine. We all know that there have been several different attempts to achieve that, and even the larger ones in the early 2000s, including stem cell therapy, gene therapies, and others, all failed due to different reasons. We developed cardiac shock wave therapy in preclinical experiments and described the molecular working mechanism in detail. I'll come back to that in a second. And found that we see a lot of new vessel formations, or angiogenesis, in small animals that we have induced a myocardial infarction and afterwards directly treated it with shock wave therapy. Then we were able to translate that into large animal trials, including pigs and sheep. And finally, we're able to perform a human pilot trial in 10 patients to assess safety and feasibility. This is a background then led to the trial that I will talk about now. But to summarize, what we found in the preclinical trials is the effects that we see is angiogenesis in the hibernating myocardium, so meaning that we recruit the chronically undersupplied myocardium around the infarction scar and thereby see the improvement of the ejection fraction. And the mechanism is that shock waves are a specific kind of sound pressure wave that we found shed off microvesicles from the cell surface. Those vesicles are called exosomes, and they act as ligands to an innate immune receptor, which is toll-like receptor 3. And this receptor, by its signaling cascades, then induces all the effects that are needed for angiogenesis. We have described that in many papers in very detail. If we use toll-like receptor 3 knockout animals, the effect of shockwave therapy is completely abolished. Just to give you an idea how this looks like, this is, this is the device in the operating theater. It's the machine that produces the energy, and this is the applicator. We will see it later on in a video directly on the heart. We cover it with a sterile cover. In this case, later on, it's a sterile product. So the trial that we performed was a prospective randomized controlled trial. We did a one-to-one randomization, and our primary endpoint was the improvement of the left ventricular ejection fraction after 1 year. Of course, we had a couple of secondary endpoints. I will show you the results later on. But to understand what we did, this chart is very important because it states that we had quite a long screening phase. Usually we get patients referred from our cardiology colleagues with an echo that say this patient has a reduced ejection fraction. And then we performed optimization of the medical therapy over 3 months. in order to rule out that we have any medication effect in the trial. Then we did another screening echo, and if the ejection fraction was still below 40%, then we did a screening MRI, because you all know MRI is more accurate and less observer dependent than echo. And only if then the patient still had a reduced ejection fraction, we included him into the study, did the procedure and had follow-up up to 12 months. In total, we screened 84 patients, included 63 of them, and randomized them 1-to-1. The main inclusion criteria were a left ventricular ejection fraction below or equal 40%, and patients who had to undergo CABG surgery, no acute patients. The baseline characteristics were well balanced between both groups. And last slide before I will show you the application and the results. And we did a lot of effort to prevent any type of bias. Some points I want to mention. We did a sham treatment in the control patients. We had an external MRI core lab that analyzed our MRI data. Patients had to be on stable optimized medical therapy for at least 1 month prior to every follow-up MRI. And what I also want to mention is that we did the randomization of the patients only at the end of the CABG procedure in order to rule out that the surgeon would have been biased in any way by knowing into which treatment arm the patient would go. This is how the treatment looks like in the OR. You see that the patient is still connected to the heart-lung machine. The heart is beating in the reperfusion phase, and it's super easy to apply this applicator to predefined areas. This was the area where the areas that we've seen in the MRI, that there were wall motion irregularities. And now to the results. We found a significant improvement of left ventricular ejection fraction after 1 year, which was up to almost 11 percentage points in the treatment group. We saw the results already after 3 months, and they were stable up to our endpoint after 1 year. We even saw reverse remodeling. The study wasn't powered for that, so the results were not significant, but I think it's important to mention that we had a reduction in end-systolic as well as end-diastolic volume of the left ventricle. And most important for the patients, if you look at the secondary endpoints that are patient-reported outcomes, we found that we had doubled the additional walking distance in the 6-minute walking test in those patients who received shockwave therapy directly after cardiac surgery, which is a major result. And of course, this also had an impact on the quality of life. We used the Minnesota Living with Heart Failure questionnaire. In this case, less is more, and as well as in the emotional and in the physical parameters, as well as in the overall questionnaire, we had a significant improvement in those patients. In order to find out whether the previous described mechanisms from our animal trials are true in those patients, we did a lot of biosampling. I will show you only a very small part of it, including myocardial biopsies before and after shockwave therapy. And we did a gene analysis of those samples and found one gene particularly high expressed that we knew before. It's called biglycan. This is a protein of the extracellular matrix and was shown to act as a ligand to toll-like receptor 3. And with that, this is the only basic science slide I wanted to show you. With that, we had a clear proof that the effect that was described before is taking place and can be induced in human patients. And now I also want to show you one more slide. This is data that is not published yet. This is the long-term follow-up of the study. It's an up to 4 years follow-up, and we see that the effect remains stable, whereas the non-treated patients get worse, and thereby, of course, the significance of the result even increases. So long-term, we can show an an 11.5 percentage point improvement of the left ventricular ejection fraction after having applied shockwave therapy directly after CABG surgery. So my conclusion really is that shockwave therapy, additionally to CABG, improves left ventricular ejection fraction, thereby brings all the effects that we expect, like improved physical capacity, improved quality of life. We anticipate that it will lower the mortality. We know that every 5 percentage point improvement of ejection fraction decreases the number of heart failure rehospitalization and prolongs life expectancy. And I think it could really cause a paradigm shift in the treatment of patients with ischemic cardiomyopathy. And speaking in front of cardiac surgeons, I can say I have the impression that this technology could further outperform PCI in patients suffering from decreased left ventricular ejection fraction. Thank you very much. I'm looking forward to your questions.
Thank you very much. That was a great presentation. A very quick question because we are 30 minutes late.
No. A question is a simple. You have done this in idiopathic cardiomyopathy in a pure model because we found that we have the only results in idiopathic cardiomyopathy that prove reverse remodeling, which is fetal stem cell at 14 years of follow-up. The problem that we face with that is that you need to have a pure model to know exactly. It's good. Congratulations.
Sorry, I didn't get that.
You know, one of the things that we face is that you don't have a pure model. It's difficult to prove totally reverse remodeling of the ventricle. That's a question. But congratulations, it's an interesting work. Okay.
Thank you.
Very good point. Thank you, everybody, and we move to the next session.